Hello everyone, I'm Dr. Quach from the University of Melbourne and St Vincent's Hospital, Melbourne, and the abstract I'll be discussing is on the safety and efficacy of Sonrotoclax in combination with Dexamethasone for the treatment of patients with relapsed refractory myeloma with the 11-14 translocation. Approximately 20% of patients with multiple myeloma carries the 11-14 translocation at diagnosis, which is associated with overexpression of BCL2 and hence responsiveness to BCL2 inhibitors. Venetoclax is a first-generation BCL2 inhibitor that's demonstrated quite robust activity in multiple myeloma for patients with 11-14 translocation, but it's yet to receive any regulatory approval for this indication. Sonrotoclax is a next-generation BCL2 inhibitor that's not only more potent, but also more selective in BCL2 inhibition compared to venetoclax in vitro. And it also has a shorter half-life in the order of only 4.5 hours. So in this ongoing phase 1b/2 study, eligible patients were those with relapsed refractory multiple myeloma who've progressed to the most recent line of therapy with the 11-14 translocation and who have failed at least 3 prior lines of therapy, including an IMiD, a proteasome inhibitor, and an anti-CD38 monoclonal antibody. And during the dose escalation phase of the study, patients were enrolled in sequential cohorts of Sonrotoclax starting at 80 milligrams daily, then 160 milligram, 320 milligram, and 640 milligram daily in combination with dexamethasone 40 milligrams weekly in a 21-day cycle. And treatment was until disease progression or intolerable side effects. The primary endpoint of the dose escalation phase was safety and tolerability, maximum tolerated dose or administered dose, and the recommended phase 2 dose. Overall, a total of 19 patients were enrolled in the dose escalation phase, 3 in each of the cohort of Sonrotoclax 80 milligram, 160 milligram, 320 milligram, and there were 10 patients in the 640 milligram cohort, and the median follow-up in each cohort ranged from around 7 months up to just over 20 months. The median age of patients was 68 years and up to 81 years old. And patients were heavily pre-treated with a median of 4 and up to 12 prior lines of treatment. And the majority of patients were triple-class exposed with prior IMiDs, proteasome inhibitors, and an anti-CD38 monoclonal antibody. The overall safety profile was quite favorable in that only 2 out of 19 patients experiencing a serious treatment emergent adverse event after a median of 7 treatment cycles and up to 30 treatment cycles. There was only 1 adverse event that led to a death, and this was a COVID-19 infection. There were no adverse events that led to dose reduction of Sonrotoclax, and indeed, no DLTs occurred at any dose level. There were 4 patients who died on study, and no deaths were deemed related to the study treatment, although 1 patient died from COVID-19 while receiving study therapy, as mentioned, but the other 3 patients died at least 50 days after treatment cessation on study and after having moved on to the subsequent line of therapy. Only 5 out of 19 patients experienced grade 3 or more adverse events. The most common adverse event was insomnia due to corticosteroids, occurring in 53% of patients. Fatigue and nausea each occurred in 37% of patients, and virtually all of which were grade 1 and grade 2. And as you can see here, there are a smattering of other grade 1, grade 2 adverse events with no one strong signal in particular. Notably, the incidence of hematologic adverse events was low, occurring in only 4 out of 19 patients, and 1 patient experiencing grade 3 lymphopenia and another one experiencing grade 3 thrombocytopenia, respectively. The incidence of infection was also low, occurring in only 6 out of 19 patients, i.e. 32%, And all of these were grade 1 and grade 2, apart from one case of the COVID-19 that we mentioned that led to death. You see here that the response rate was quite remarkable, acknowledging that there is a small number of patients. You see response starting to occur in the cohort of 160 milligram, in which all 3 out of 3 patients responded and 1 patient achieved a CR. In the 320 milligram cohort, 2 out of 3 patients achieved a partial response, and of the 10 patients in the 640 milligram cohort, the response rate was 70%, with stringent CRs and CRs documented, and VGPR or better occurring in 40% of patients, and notably these patients were heavily pretreated with a median of 4 prior lines of therapy. The longest duration of response was in the order of 19 months, which was still ongoing at the last assessment. So overall, Sonrotoclax and Dexamethasone combination was very well tolerated in a group of heavily pretreated patients with no DLTs observed at any tested dose level, and the majority of patients experiencing only grade 1 and grade 2 adverse events. Hematologic toxicity was notably low, as was the risk of infection, with only 1 infection that was grade 3 or more being COVID-19 infection. Sonrotoclax dose of 640 milligram is being brought forward as the recommended phase 2 dose and is being evaluated in an expansion cohort, as well as dose-finding cohorts in combination with carfilzomib. And I think overall, the emergence of this very potent second-generation BCL2 inhibitor with a favorable safety profile brings much promise to the group of patients with 11-14 translocation, which nowadays represent a group that tend to benefit not as much to novel therapeutic agents compared to the other standard risk group of patients with multiple myeloma. I'll end there, and I thank you for your attention.